Good morning, everyone from Europe. It's my pleasure to be and hold this joint seminar from ESNM and the Korean Society of Neurogastroenterology and Motility at this early morning for us in Europe. I really look forward to having an interactive talk today. We will have two excellent professors talk to us about fecal microbiota transplantation. The first being Professor Edoardo Savarino from the University of Padova, who will give insight on the European role, the European way of clinical applications of fecal microbiota transplantations. And afterwards, we'll have Professor Shin, who will be introduced again by you, Professor Choi. So it's my pleasure that we have this joint symposium this morning. We'll also allow for some questions and answers. And it's my pleasure now to announce Professor Savarino to please start and give us his talk.
The program was the Korean part was before the European part. So
let's stick to that then. And then please, Professor Choi, give a few words of welcome also to Professor Shin, and then let him please start with the first talk.
I will divide my presentation into introduction, history of FMT in Korea, controllable factors for success of FMT, and studies of FMT at Ina University Hospital. This is introduction. Microbiome is the compound word of microbiota, which means microbiome community and genome. Microbiome has recently been used to refer specifically to the community of microorganisms that exist within the human body. Most of them belong to the four phyla: Bacteropodetes, Firmicutes, Proteobacteria, and Echinobacteria. The healthy digestive system harbors a large amount of microbes, which is tenfold higher than the number of cells that make up the body. Most of them are contained within the colon, 95%. It is known that the microbiome, which plays various roles, influences human organs. The relationship between each organ and the microbiome is co-axis, such as gut-brain axis, and it influences almost the organs of the human body. The disruption of microbiome function is now traced in part of the genesis of many medical conditions, not merely localized to the gut. We call these disruptions dysbiosis. Recently, studies have begun to correct disease conditions caused by dysbiosis. Microbiome therapy can be defined as method of treating disease by correcting dysbiosis using the microbiome. In an effort to restore the microbiome network in diseased individuals, 3 therapeutic strategies that leverage the microbiome have been designed: additive therapy and substrate therapy and modulatory therapy are commonly used strategies for microbiome therapeutics. Subtraction therapy is the treatment method that removes the resident pathogen by bacteriocin or bacteriophage. Modulated therapy is the method of modifying or manipulating the host microbiome interaction for certain function using a certain non-living agent. Additive therapy is the correction of dysbiosis by adding microbial strains or microbiome communities, and fecal microbiota transplantation falls in this category. Fecal microbiota transplantation, FMT, is the transport of donor stool to recipient gastrointestinal tract with therapeutic intent. FMT is microbiome therapy, as mentioned above, one of the additive therapy. This treatment has been shown to restore a disrupted microbiome ecosystem and related microbiome functional network. FMT is recommended in several international guidelines as an effective treatment option for recurrent CDI. To understand why FMT treats success and success varies depending on the disease, it is necessary to examine the mechanism of FMT. In this biosis, social fatty acid diversity and secondary bile acid mucose decreases, and it causes inflammation, immune dysregulation, and metabolic aberrances. FMT restored beneficial attribute of microbiome. The restorative effect of FMT operates through direct and indirect pathway. The effectiveness of FMT was first officially recognized in 1958 by surgeon Ben Eisman. He treated 4 CDI patients with FMT via enema, and the efficacy was 100%. FMT is a treatment method with a long history, dating back over 65 years since its first literature report. In 2013, a comparative study of vancomycin and FMT in the treatment of CDI was reported in NEJM, and the effects were quite surprising. The therapeutic effect of FMT in CDI has been constantly replicated in other comparative studies. Due to prior outstanding studies, FMT is now well known as an established treatment for recurrent CDI. There is also increasing evidence for the efficacy of FMT in inducing remission for mild to moderate ulcerative colitis and functional constipation. Although there is not yet sufficient data on the effectiveness of FMT in other indications, it is actively being reached because of its therapeutic potential. The reason why we should pay more attention to FMT is that FMT has strong and safe effect in correcting microbiome dysbiosis. As a result, FMT occupies most of microbiome therapeutic markets, 19%. So far, I've briefly talked about FMT, and from now on, I will talk about the history of FMT in Korea. The first literature report on FMT treatment in Korea is a case report of a patient with refractory CDI successfully treated with FMT at the Catholic University of Korea St. Mary's Hospital in 2013. In this case report, the patient received a stool transplanted through FMT from the patient's family daughter. The second literature report was in 2015, a case report of a patient with toxic megacolon due to CDI treated with FMT. The patient underwent FMT via colonoscope and was successfully treated. The third literature report was a case report in the 2016 of a patient with severe refractory CDI who was treated with FMT despite 1 month of vancomycin treatment. In Korea, FMT, as previously introduced, remained as an optional treatment method through researcher-led clinical trial. In 2016, FMT was finally recognized as a new medical technology in Korea, making it available as a treatment option for CDI patients other than the full research purpose. Since then, FMT has begun to expand it in Korea. Many guidelines related to FMT have been published recently. The clinical practice guideline for FMT in Korea was published by JNM in 2022, and almost all FMTs in Korea are being implemented in compliance with the recommendation of this guideline. From now on, I will tell you about the current status of FMT in Korea. There are 3 stool banks operating in Korea, excluding those operated for institutional use at university and hospital. Among these, microbiotics and biobank healing are active in supplying stool for FMT transplantation. All stool banks maintain a stool amount of more than 50 grams and are still conducting COVID-19 tests. In 2022, the Korean Association for the Study of Intestinal Disease, the KSNM, conducted a multi-center study to determine the impact of COVID-19 pandemic on the implementation of FMT in patients with CDI and its efficacy and safety. In this study, FMT in Korea began increase rapidly from 2017, and approximately 50 cases of FMT were performed on CDI patients in 2020. In 2021, it decreased slightly due to the COVID-19 pandemic. Most FMT performed in Korea were performed with stool donated by universal donor, and only 2017 to 2018, FMT with fresh stool from relative donors was performed, which completely disappeared from clinical practice along with the COVID-19. Capsule FMT was performed only in a few institutions, and it's gradually increasing as the supply of capsule FMT from stool banks becomes smoothly in 2021 to 2022. In 2023, approximately 10% of FMTs performed in Korea were performed with capsule. The CDI cure rate of FMT in Korea was excellent at 85.2%, which is very similar to in previous literature. And the recurrence rate within 8 weeks after FMT was low at approximately 15.2%. Adverse events related to FMT are diverse as shown in the table, but most are minor events. Nausea, vomiting, abdominal discomfort, and bloating are known to be commonly observed adverse events. It is known that complications related to colonoscope for FMT and aspiration pneumonia observed during upper route FMT can lead to fatal outcomes. Adverse events in FMT performed in Korea were similar to those reported in the literature mentioned above. Adverse events FMT were observed in less than 10% of patients, and nausea and vomiting were most common. Nausea and vomiting were observed more frequently in FMT via the upper route. In one case, the elevation of liver function test result was several times higher than the upper limit of normal, showing acute hepatitis. Fortunately, LFT improved after conservative treatment. Recently, the US FDA approved FMT solution, and FMT capsule formulation as microbiome therapeutics and boost and revive them. The related guidance is early clinical trial with live biotherapeutic products provided by the FDA in 2016. In Korea, there's not specific regulations or restrictions related to FMT yet. As research related to microbiome increased in April 2022, the KFDA announced the quality guidelines for clinical trials of probiotic therapeutics. Refers to the guidance announced by the FMT in 2016. However, it does not include content related to FMT. Therefore, research related to FMT is currently being conducted by researchers on their own according to the published guideline, and discussion and actively underway between the government and research institution. Let me share my experience with FMT and in our university hospital. This photo shows the member of Incheon University Hospital Microbiome Center The Incheon University Hospital Microbiome Center consists of medical staff from the Department of Gastroenterology, Infectious Disease, Hospital Medicine, and Neurology. And we operate own stool bank, receive stool donation from the 3 carefully selected donors. This graph shows the number of CDI patients treated at Incheon University Hospital. The number of patients decreasing during the COVID-19, but began to increase again in 2023. And the number of patients treated with vancomycin is gradually increasing compared to those treated with metronidazole. As of 2023, FMT was performed on just 7.6% of patients. Including FMTs performed for indication other than CDI. An average of 60 FMTs were performed annually, and in 2023, approximately 7 FMTs have been performed. 62% FMT was performed in patients with CDI, followed by IBS, multidrug resistant organism, MDRO, ulcerative colitis, and autism disorders. Now, based on my experience with FMT, I talk about what are the controllable factors for successful transplantation in clinical practice. The first controllable factor is the donor stool being transplanted. The donor stool is composed water and dry solids. Dry solids are composed of donor chronocyte, microbe, and metabolite. This composition varies depending on the donor's diet, age, genes, and environment. Therefore, there are various differences between people, and even within the same person, differences occur over time. So, super donor has been proposed to describe a donor whose stool result is significantly more successful FMT outcomes than the stool of other donors. Therefore, it is important to secure a donor with an excellent microbiome profile. Since it is not easy to identify a super donor and secure the corresponding stool, it may be helpful to use stool fortified with key taxa or prebiotics depending on the characteristics of target disease. But there is almost no research on this yet in my knowledgement. And even if the super donor, there are differences in the characteristics of the microbiome depending on the time of donation. This is figure show the beta diversity stools received from same donors, and as you can see, there is some diversity even though the stool are from one donor. In order to control quality, it is necessary to reduce these differences and ensure that they have consistent characteristics. To mix this stool, our own method, after that, the mixed stool has more similar diversity characteristics. The second is bowel cleansing. Because the less stool there is left in the recipient colons, the less interference there will be with the patient microbiome. The third is bowel transit time. Stool usually remains in the colon for more than 48 hours. However, when you do FMT, you will often experience defecation within 12 hours, something just 10 minutes. Therefore, administering an antiplasmotic agent to keep it in the colon for a longer period of time may be helpful. Additionally, infusing the FMT stool in the cecum as much as possible will increase bowel transit time. However, even when infusion the cecum, we have observed many cases where the stool flowed out during the procedure of withdrawing the scope. So we tried to patient position as shown in this picture, right? Just leg down. This posture is to position the cecum in the direction of gravity. And when withdrawing the endoscope, we were able to observe that the stool did not come down any further as shown in this picture. Therefore, since 2023, if there is no problem with the position of the patient who received FMT, our hospital performed FMT infusion in the light decubitus with leg down and has patient maintain that position for as long as they can tolerate. Now, for the last part, I'd like to share my research experience related to FMT. In Korea, fidaxomicin administration is impossible due to supply problem, so CDI is treated with metronidazole, vancomycin, and FMT. In the case of metronidazole, bioavailability is high, so most of it is absorbed, and it tends to have a high recurrence rate due to microbiome disease caused by the drug. The metronidazole kill or almost unable organisms. So, to confirm this, a study was conducted to compare the recurrence rate microbiome profile in patients treated with 3 treatment methods. The overall recurrence rate after 8 weeks of treatment was 13%. The recurrence rate after FMT was just 12.5%, which was the lowest rate. We found that the microbiome diversity, alpha diversity, was distinctly decreased in metronidazole group and compared to other group. And the composition beta diversity differs. This is donor, this is metronidazole, this is vancomycin, and FMT is so different significantly. Comparing the FMT group with other treatment group, it showed that microbiomes has been a function such as butyrate production had rich composition. In vancomycin group, Fusobacterium, Browsia marcia, and Clostridium inoculum were more abundant on one of them. And one of them, Clostridium inoculum, is known to cause vancomycin-resistant opportunistic infection in immunocompromised patients or cause diarrhea that is clinically indistinguishable from C. difficile. It is also known that in the case of Alzheimer's dementia patient, the progression of this disease is accompanied by change in the gut microbiome. Related concept is brain-gut microbiome axis. We conduct a study on patients who underwent FMT at our hospital to see if cognitive function improved in the elderly patient over 17 years. We were able to confirm that MMSE mini-mental status exam scores improved FMT and observed further increases after second FMT. So we are currently conducting additional studies to analyze how the composition of microbiome changes and how much it improves in patients with cognitive decline after FMT. Another study conducted at our hospital, the Microbiome Center, looked at the effect of FMT on MDR or multidrug-resistant organism, CRE or VRE. Patient harbors multidrug-resistant bacteria can spread them and cause a serious antibiotic-resistant problem. However, the method for decolonizing these multidrug-resistant bacteria are very limited. We performed FMT on 52 patients with confirmed multidrug-resistant bacteria and evaluate the effect of FMT on the negative conversion rate of this. The result of study shows that the negative conversion rate was high at 32% in group that underwent FMT, and the negative conversion rate after 3 months was significantly different from the control group. There are also cases of uncommon disease treated with FMT. Cronkite-Kanada syndrome is a rare non-hereditary disease of unknown etiology that is characterized by appearance of multiple leaves in entire gastrointestinal tract, except in Asperger's, with GI or non-GI symptoms. This patient did not respond to steroid therapy. Unfortunately, infliximab administration was not possible because active tuberculosis was suspected. The patient complained very severe diarrhea, and since GI symptoms were the most uncomfortable factors, FMT performed after consultation with the patient. After FMT, the patient diarrhea improved rapidly, and the albumin level returned to the normal, and multiple polyps was disappeared like this. This patient tested the stool pre and after FMT. In patients with bronchitis syndrome, Canada syndrome, the Hwan index for specificity was increased. Fusobacterium nucleatum, as you know, is a cause of the colon cancer, and Pyramidobacteria pisciculum and Campylobacter congensis disappeared after FMT. Recently, research on the microbiome and the relationship between worsening UC and this biopsy has been conducted. Further investigation on the association between the microbiome and secondary error are increasing. So we present that therapeutic impact of FMT on 42-year-old man with a secondary error of and high ADA levels. Stool samples were collected from the patient before and 4 weeks after FMT. Symptoms including hematochezia and Mayo endoscopy subscore improved after FMT, while ADA level decreased by 1/3 to less than half the value to 29 nanogram per milliliter compared to before FMT, 79 nanogram per milliliters. Additionally, the through trough level of infringement become measurable, which reflect the improvement in the area under concentration. Pityricoccus, Becalobacterium, Bifidobacterium, and so on, which regulate immune response, alleviated inflammation, also increased after FMT. This is the last slide of my research experience on FMT. FMT was performed on patients aged 5 to 7 years with autism disorder. FMT was performed twice at 1 month in the intervals, and statistically significant decrease. CAS score was confirmed, beta diversity similar to the donor, and Bifidobacterium bacterial test and Pityricoccus is increases. I'd like to summarize my presentation. FMT is promising microbiome therapeutics. The indication for FMT are expanding, and continued research is needed to elucidate the impact of FMT in various diseases and the characteristics of a patient who require FMT. Consideration of the procedure for successfully performing FMT in actual clinical practice is also necessary, and research on this is also required. Now I will close my presentation. Thank you for your listening.
Thank you, Professor Jongbeom Shin, for your very excellent lecture. I think it is better we have discussion time after all 2 lectures. So I would like to hand over the moderation of this session to my co-chairman, Professor Daniel Pohl. Could you?
One excellent talk. I would like to introduce our next speaker, who's Professor Edoardo Savarino, who's a professor at the University of Padova. He has a vast interest in neurogastroenterology, also in immune-mediated diseases, and he does have a very good experience in fecal microbiota transplantation. Padova being one of the first pioneering centers in Italy to actually start this program. So please, Professor Savarino, give us your insight on practical clinical applications in Europe.
Thank you, Professor Pohl, and thank you also for this kind invitation to present today at this nice symposium. I also would like to congratulate with my colleague for the very, very excellent presentation regarding the use of FMT in South Korea and more in general regarding the information he provided about the rationale of FMT in clinical practice today. I will do a brief background regarding the FMT in Europe, but I promise I will be short. These are my conflicts of interest, and indeed, we know that there are different factors that may influence the development of dysbiosis or loss of eubiosis, which is strictly related to different disease, as demonstrated by literature in the last 10 to 15 years. Indeed, there are lots of examples where altered microbiota plays a major role in the pathogenesis, development, and probably also response to treatment in different conditions, also extraintestinal conditions like GI infection, Parkinson's disease, rheumatoid arthritis, lupus, inflammatory bowel disease, colorectal cancer, liver disease. Of course, from a gastroenterological perspective, the role of microbiota plays a major role, particularly in inflammatory bowel disease, where microbiota alteration have been studied since 40 years, and we have evidence regarding a different distribution of microbiota in patients with ulcerative colitis and Crohn's disease, and we were able to identify family and bacteria which are deeply involved in the development of these two conditions. More recently, in gastroenterology, has been published this important paper from the United States, where the authors found a clear association between gut microbiome composition and the future onset of Crohn's disease in healthy first-degree relatives. This is a really, really important paper which has clearly how the microbiota impacts on the pathogenesis of these two conditions. Again, in GI field, probably the other aspect we should look at is the association between microbiota composition and colorectal cancer. There are several studies published so far, few of them in very good journals showing clearly an association between microbiota composition and colorectal cancer, left side or right side colorectal cancer, and more in depth about the response to different cancer conditions, to different treatment, including the use of immune checkpoint inhibitors. But we will look at that thereafter. We know that for modifying the gut microbiota and to induce a restoration of a healthy microbiota, there are different approaches we can use. The diet, we know, is one of the major driver of microbiota composition. Antibiotics, which work quite well, but unfortunately destroy also the healthy microbiota, and prebiotics, probiotics, which unfortunately are not really effective, particularly in the long term, and the fecal microbiota transplantation. The fecal microbiota transplantation is considered today as the main treatment of many intestinal and extraintestinal disease. It involves the engraftment of the gut microbiota of healthy individuals into disease recipient to reconstitute a normal intestinal microbiome composition. We know that we can use different types of suspension of fresh feces or frozen feces. I saw some slides before from the presentation that have been done before us, and I can say that now most of the centers also in Europe use frozen feces, which are effective as fresh feces in terms of efficacy and also in terms of safety. There are different ways of administration by enema, transcolonic infusion, nasoduodenal or nasogastric infusion, capsule, pills. The most used in Europe now is the transcolonic infusion, much more effective, particularly in colonic condition or extraintestinal condition. And nasoduodenal or nasogastric infusion is used when more in research setting, when repeated FMT needs to be done. There are some basic instructions that have been highlighted in this guideline published on GATT. The first author is Giovanni Camarotta, who is a full professor of gastroenterology at Gemelli Hospital in Rome. These few rules perfectly identify what we need to do for doing a good FMT and for obtaining very good efficacy, particularly in CDI or refractory CDI patients. There are evidence for different indication of fecal microbiota transplantation in 2024. I have summarized here the most commonly used of FMT in Europe. The only formal approved indication is the Clostridium difficiloides infection, for which we have outstanding efficacy data I will show you later on. There are other promising field settings like IBD, ulcerative colitis, particularly liver disease, including hepatic encephalopathy or metabolic syndrome. There are some data, particularly the last one, showing promising data also in irritable bowel syndrome and multi-resistant infection. Unfortunately, we have a few data regarding the use of FMT in neurologic diseases like autism with poor results to date. On the other hand, the data regarding the use of FMT in chemotherapy-dependent diarrhea and in patients undergoing immunocheckpoint inhibitors are quite promising, and this is probably one of the future landscape of FMT in clinical practice. Going back to Clostridioides difficile infection, we know that this is a gram-positive bacteria, spore-forming, resistant to common sterilization technique. It causes 1 out of 5 of diarrhea associated with antibiotic therapy, and 60% of the isolated strains are multi-drug resistant. We know that the antibiotic resistance trait in the United States is particularly relevant. Similar data are available also in Europe, probably with a little less percentage of infection per year, and that's per year, but for sure is a common clinical problem in every hospital, particularly in ICU or in long-standing ward units. FMT in Clostridioides difficile infection is a success story. We know also from my colleague the application of FMT in this setting. The first reported application was in 1958. Then different randomized control trials have been published comparing FMT with vancomycin, fidaxomicin, and also Microbiota Consortium, showing that FMT is really, really effective, reaching a percentage of effectiveness of about 90-95% with a very, very safety profile. For this reason, FMT has been introduced in the American Gastroenterology Association guidelines, the guidelines of infectious disease in the United States, in Europe, and of course, we published in 2017 and more recently on stool banking, also in Europe on GATT, recommending the use of FMT in clinical practice as a highly effective and safe treatment option for both mild and severe recurrent CDA. FMT can be considered as a treatment option for refractory CDI, and in frail patients could be also used as a first-line treatment when particularly vancomycin or metronidazole fail to be effective. This meta-analysis and randomized control trial show the data regarding the efficacy of the treatment. You see between 90 and 95% of efficacy. In one of the last meta-analyses published by Gianluca Ianniro in 2018, the overall effectiveness of FMT reached a 93% of rate. We know from other studies from PubMed, from medical literature, that treating FMT cuts the need for C. diff-related surgery, prolonging survival of the patient and reducing, of course, mortality. Not only the mortality related to the infection, but also the mortality related to surgical procedure. Moreover, the treatment with FMT is related to a reduced probability of having primary bloodstream infection, which was one of the main concerns related to the FMT procedure when we started to use it. As mentioned before by Professor Pohl, we were the first or the second center in Italy to introduce in clinical practice the use of FMT. This was done, the first procedure was done in 2015. The approval from the ethical committee, Central Ethical Committee, was in 2016. And then we had also rules provided by the healthy government in Italy, which approved the use of FMT later on, only in 2021, but we obtained also the authorization of performing FMT also from the Italian government. And now we can see that we use FMT in clinical practice more or less as the Professor Shin showed before in his center in South Korea. We published some evidence also regarding the efficacy in our cohort of CDI refractory, multi-refractory patient, because these patients were refractory to vancomycin, metronidazole, and also fidaxomicin, with an effectiveness of 85%, with mean days of hospitalization of 7.4. And we provided also data regarding metagenomic and safety. The safety was very, very good. A very few number of side effects, mainly related to fever and diarrhea. How to evolve FMT? Explore new indication, guarantee safety, standardize and disseminate, improving working protocol, and also we need necessary mind shift. As to potential new indication behind C. diff, we know, and as neurogastroenterologists, we aim to treat a condition like irritable bowel syndrome, where dysbiosis plays a major role. And we know that from the literature regarding the post-infectious irritable bowel syndrome pathogenesis and a clinical implication. Unfortunately, the randomized control trial done until 2019 were not really convincing in terms of effectiveness and safety. Indeed, the efficacy was mild. The placebo capsule were superior to fecal capsule, and unfortunately, only the FMT from donor stool delivered via colonoscopy was superior to autologous stool. The side effects were not so frequent, but there is a clear reasons for this debug in IBS. You know that there were used different working protocols for doing FMT in patients with IBS. It is believed that capsule probably could worsen small intestinal bacteria overgrowth, which is a condition of frequently overlapping with IBS, and probably the classification of IBS should be a little bit modified in order to understand which patient with abdominal complaints may respond to this type of treatment. Luckily, more recently, another paper published on gut in 2020 showed a different approach of FMT in IBS. They delivered a high quantity of microbiota through upper GI delivery from a single super donor, and they checked the effectiveness at 3 months, showing a very, very good efficacy as compared to placebo, using both the 30 grams and 60 grams with a reduction of both fatigue and improvement of quality life in these patients. Another potential setting where FMT could play a major role is a high BD. There are different randomized control trials published today. This meta-analysis refers to the first 4 studies in which the treatment of FMT resulted to be effective with clinical remission of about 28%, endoscopic remission of about 14%. And also, they summarize data from 14 cohort studies, which show a clinical remission of about 24%. However, as you can see, particularly for the fecal infusates and the FMT protocol en route, they were really, really different between each study. So a clear comparison between them is particularly difficult. And anyway, the rate of remission were not adequate enough to recommend this treatment in ulcerative colitis patient. This is probably related to the fact that we don't know if certain donor microbiota profile may be more effective. There is also a concern regarding the fact that this is a chronic condition and then should be treated chronically also with FMT and not in acute. Luckily, another study was published more recently regarding the use of lyophilized FMT for UC. The results you see at the bottom of the slides were very, very positive, with clinical results very good as compared to placebo. Unfortunately, the sample size was small, but this study and the use of this type of approach of FMT chronically for this patient is very, very interesting to be used in clinical practice. Another interesting study was published on gut in 2022. This was a combined approach of FMT plus diet in patients with ulcerative colitis with less than 1 year from the diagnosis and in mild to moderate ulcerative colitis. Again, this study showed promising results in terms of clinical response, steroid-free clinical remission, deep remission, because the difference compared to placebo was quite high. And the safety, again, was very, very good in favor of the use of FMT without relevant side effects observed during the trial. For all these reasons, a consensus was published last year in GUT, the first international Rome consensus conference on gut microbiota and FMT, inflammatory bowel disease, which provides statements and recommendation of the role of microbiota in IBD, and also statements regarding the donor selection, biobanking, and potential trials in IBD. A second consensus will be held this year again in Rome in December, where probably multi-center randomized control studies, a pragmatic trial in IBD will start, including multi-center in Europe, to show the efficacy of this approach in IBD. Other evidence on the use of FMT outside CDF come from tumors, particularly for the use of immunotherapy against epithelial tumors. These are the rationale behind it published on Science, but more recently, data on natural communication of the efficacy of FMT in treating the diarrhea induced by cancer therapy, and also to improve the response to immune checkpoint inhibitors in epithelial cancer came from literature. There are different trials ongoing in humans, some in Canada, USA, in Israel. There is an ongoing randomized control trial in patients with melanoma. In Italy, there is a randomized control trial in renal cell carcinoma patients. Of course, in parallel to new indication, we have to prove and to guarantee the safety. The safety in the short term now is very, very high, particularly after these awards from FDA a few years ago, showing that we have to strictly control the donor and the feces with storage in the stool bank. And there are some concerns regarding the long-term safety because of the new evidence regarding the microbiota. But you see from this trial, from this study published in 2019, that the transplanted potential dangerous Fusobacterium nucleatum was reversed in patients who underwent FMT, repeating another FMT, changing again the microbiota. We need standardization, the relevance of stool banks, and shown by Professor Shin before. We have a consensus here in Europe regarding the stool bank, and also in parallel in the United States, the registry was approved by the AGA and FDA in order to have standardization of the procedure. We know indeed the barrier that prevent the diffusion of FMT are related to safety, lack of dedicated center, bureaucracy, and donor recruitment, and for sure, having stool banks may overcome this limitation and make this therapeutic option available for all patients. We have to improve the working protocol. We need now that probably the FMT success is a matter of quality, superdonor, and quantity of feces delivered. There are different evidence in literature suggesting that severe disease, inadequate bowel prep, and hospitalization may predict CDI recurrence after FMT. We know that patients with an early disease like ulcerative colitis may respond better to FMT rather than patients with long-standing condition. We know that the routes of delivery is particularly relevant as the fecal amount of infusion. And there are, of course, microbiological predictor of FMT response regarding the patient microbiota, but also the donor microbiota, which we should look at in order to improve the quality and the success of our FMT. The key role, indeed, is the engraftment. Professor Shi showed how to improve the engraftment by using loperamide, changing the position of the patient, using antibiotics before treating the patient with the FMT, and probably one of the key rules for improving the engraftment is repeating FMT during a time. Multiple infusion indeed are better than single infusion and may increase the rate of success of the protocol. Probably in the future, this will be the option to deliver FMT in a chronic way in order to use everyday FMT in our patient and in order to improve the efficacy of FMT in patients with chronic conditions like IBD and IBS. This is a clear example of where the literature and more in general, the medicine is going for treating patients with fecal microbiota transplantation. Are also necessary mind shift, because we know that chronic diseases are lifelong and FMT is unlikely to act as a one-time treatment. Probably FMT should be considered as a chronic treatment to be integrated among other options. We need to improve our knowledge regarding specific donor microbiota signature, and we need to develop also more microbiome infrastructure with a microbiome clinician, microbiome clinic, in order not only to improve the knowledge regarding the role of microbiome, but also to show strong evidence about the efficacy of this kind of treatment. Thank you for your attention.
Thank you. Thank you very much for your very excellent lecture. And I would like to invite a question from the audience. Could you please? Yes, Professor Na-young Kim, please.
My name is Na-young Kim from Seoul National University. Thank you very much for your excellent lecture. I have two questions to both of Professor Shin and Professor Savarino. Even though there is no indication of FMT in irritable bowel syndrome, right now I am doing some FMT in the IBS patients because of national grant. So my question is that we usually doing IBS D and C for by oral approach without bowel preparation. I found that the effect was very good in the IBS-C type, constipation type, especially female. So to both of you, the professors, what's your opinion for this oral approach without bowel preparation? First question.
I can answer before, if it is okay for you, Professor Shin. I have also experience with in patients with IBS, particularly if they are proved to be really, really dysbiotic, because we do, of course, microbiota signature and of these patients. And we had a few patients proving more effectiveness in IBS-D rather than IBS-C. But if we look at literature data, particularly regarding fatigue and quality of life, we saw also that FMT is effective also in patients with IBS-C. So probably you're right, saying that this can be an option. Regarding the lack of bowel preparation, I'm a little bit more concerned because most of the evidence we have available now suggests that in order to improve the engraftment, in order to change significantly in microbiota, we need to do it the right way. Otherwise, the probability of changing his microbiota of the patient is quite low.
Professor Shin.
Yes, thank you, Professor Shin.
In my opinion, in my experience, this is depending on the patient dysbiosis status. So I recommend that some patient who have IBS-C type, if the patient have some more dysbiotic pictures after the FMT via the colonoscope and continuously regularly approach it via or oral FMT can help the constantly the change it and recovered microbiome is help the symptom relief. So oral approach is a good choice of that type of patient, but I recommend some patient who more dysbiotic pictures after FMT via colonoscope and oral approach. I plan Thank you.
Thank you very much. For the second question is that actually there is some sex difference of immune mechanism and microbiota. I guess there is some the difference of the effect of FMT between females and males. What's your opinion?
In that part of the sexual difference, unfortunately, we have some female donor recently get. So I have just one super donor, the male. So I totally agree with your opinion, but my experience and the stool affected according to the sex, is my experience is too low to explain that.
I found that the donor is male, usually some kind of some physically active the males.
Yes.
My question is recipients. If the recipients, there are some male and females, but usually the analysis performed by some donor or disease or other things. But there should be some such difference of immune and microbiota situation. So in terms of recipient, is there any analysis regarding sex difference defect?
I have no data about that. Sorry about that.
Professor Savarino, do you have any data, the efficacy of FMT according to the gender? Is it any difference according to the gender, recipient gender?
Thank you. I got the question. And I believe that probably the colleague is right, saying that probably there is a difference because the immune mechanism, particularly at the bowel level, are different from male, females, and also the microbiota studied in other indication, not for FMT, but for IBD or IBS, is completely different within different gender. Unfortunately, there are no data for the effectiveness of FMT in males versus females because, you know, from randomized control trial, the sample size is always very, very small, between 30 to 40, maximum 50 patients. So stratification according to gender is almost impossible, but I believe that in the future there will be something to look at because I have the impression that indeed there is a difference in terms of effectiveness according to the gender of the recipients.
Okay, thank you. And I have one question. Can I ask the cost of the FMT procedure in your country? I think in Korea, the FMT procedure cost about 1,000 US dollars about.
Okay. I mean, here the answer is a little bit more complex because in Europe it's not equal in every country. For instance, in Italy, FMT is considered, the feces is considered like an organ. So it follows the rules of organ transplantation like liver, kidney, and so on. While in other countries like France, for instance, is a drug. So it's a little more easy. In Italy, we have to follow strict rules, like particularly for the donors. So they have to follow the rules of the liver transplant patient or kidney transplant patient. So the number of examinations they have to undergo before being able to donate or doing the FMT is quite high, and so the cost is probably a little bit higher than the one you have in South Korea, is about 1,500, and this has to be repeated every 6 months, of course, in order to be sure that nothing changed a lot. But for the procedure, it's very cheap because, you know, it's just a colonoscopy. The patient usually is already recovered in some ward in the hospital. and the drug used for preparing the patient and loperamide after the procedure are very, very cheap. So it's a quite low-cost procedure, particularly as compared to fidaxomicin, which is a quite high-cost antibiotics, at least in Italy.
Thank you. And recently, two fecal FMT material was allowed to use by FDA. I think the product name is both Rebiota. Those are available in your country. Can you use them?
They are not yet available. We saw some slides also from Professor Shin. I showed in my presentation one slide regarding the use of this microbiota derived from stools of healthy donors. And this was found quite effective in treating Clostridioides difficile infection or resistant patient in order to reduce the recurrence. Was approved in the United States. Both the products you mentioned, there is another one on the way of being approved, and probably the future is there because you know that this could reduce a lot the cost regarding the application of FMT and also make easy and available the use of FMT in every hospital or in every center, healthy center in every country. So I believe that the future is there, but we need more time and probably more evidence before doing that.
Thank you. Thank you. Do you have any? Yes, Professor Kim.
Thank you for nice lectures. I am Yong-Sung Kim from Wonkang University. When FMT is conducted for non-CDI indications such as autism or IBS, is the antibiotic preconditioning essential or not? I wonder that both the opinion of you both.
That's a good question. Indeed, I believe that the data regarding the use of antibiotics pre-FMT are quite good. And we moved from not using to using it because of the data and because also in our clinical practice, we saw a bit of difference regarding its use. So from my perspective, and also supported by medical literature, should be used. And there are different possibilities because I didn't show you the data regarding use of rifaximin, for instance, which is orally not absorbable antibiotics, which is very, very effective at bowel level without any concerns regarding side effects and development of MDRO. So I believe that the use of rifaximin or similar antibiotics should be more used in clinical practice and recommended by guidelines. Probably in the future will be done. But I suggest to use it.
Thank you.
Thank you.
I'd like to ask questions. I don't know if you guys can hear me.
Yeah.
So that's the question that goes to both speakers. Professor Shin showed his experience in treating patients with autism and also MDRO with FMT. Now I know Professor Savarino, you also have experience. I believe you also did some research regarding autism, and you also looked at severely immunocompromised patients, such as transplanted patients. So could you comment? And then also you showed that the data overall that are currently out there from your meta-analysis regarding the treatment of autism are not so good. So what's your personal take on that, and would you also comment regarding severely immunocompromised patients?
Could you severe immunocompromised patient, the use of FMT for the immunocompromised patient? The question.
Yes.
I have just one case in immunocompromised patient because the severe infection of CDI, the leukocytosis is 13,000 WBC checked from the initial treatment. So, and any other immunocompromised status after chemotherapy or ETC. So unfortunately I have just one case and in immunocompromised patient.
Good, the efficacy is good for the patient?
Yes, the patient FMT 1 weeks and totally 3 times. And then she has totally recovered the CDI infection, and leukocytosis is recovered to normal range of. Yeah.
Okay, Professor Savarino, do you have any experience about the use of FMT?
Yeah. We have a bit more experience, particularly in liver transplantation and kidney transplantation. Treated not only for C. diff, resistant C. diff, but also with other infections like New Delhi, or also virus infection like norovirus and so on. And we found that there is no increased side effects related to the immunocompromisation. The main concern or limitation regarding the efficacy is that is mostly related to the fact that these patients are usually on antibiotic, antimycotic, and different treatment ongoing, But the efficacy is, I would say, the same in normal patients, and there is no impact of any treatment in terms of efficacy rates or safety. In autism, we have some experience, not a lot, to be honest, because the main concerns regarding autism is the understanding of the efficacy, because the neuropsychiatric assessment should be done before FMT, after FMT, and it's very, very challenging to understand if the FMT was effective or not. We had some patients who have been treated 1 to 3 times, and some other just 1 time. My impression is that 1 time in a patient who previously responded to antibiotic therapy, who is more effective. If the patient did not respond before to any kind of treatment able to modify the gut microbiota, probably he will never answer to FMT, but it's a personal opinion. It's not anything published.
Thank you.
Thank you. Professor Pohl, do you have any question or comment?
Yeah, maybe one more question to Professor Shin. You showed us that there is a Korean guideline of how to do the FMT. Now, and you also told us that you have these biobanks available in your country, different ones, which have the stool available. Now, as a Korean institute, how do you get access to that stool? Can you do it just under research purposes for other indications than CDI, or do you have easy access to get the stool to centers that don't have a lot of experience or want to use it again for other indications than CDI?
Do you mean the route to get the FMT material?
Yes, to get it from the stool bank. Is that easy or difficult for you?
Yes, Professor Shin, can you answer the situation in Korea? Okay, can you answer how to get FMT material?
What is the point of the question? Because this is standing on
the root.
behind
The root, you can get the fecal material for treat or study the fecal FMT material. How to get? It is easy or difficult to get?
Yes. We have own stool bank, and we can use the commercially used stool from the stool bank other side outside in our university. In the study, we do the same stool in our stool bank, so we can easily approach the study by FMT in own stool bank, because we operate this stool bank just academic course for the treatment of CDI. So our supply of stools for the CDI and study is enough to that. So we have this is our strengths in the FMT study in United University Hospital.
Actually, I have some added.
Yes, please, Professor.
My senior professor, the faculty, Lee Dong-ho, opened venture, some kind of provide the fecal material commercially. So it is about $600, and usually in our hospital we receive $1,000 for procedure, whole procedure, for colonoscopy or some endoscopy, upper endoscopy. And even there is indication, but in our country there is some kind of some experimental some indication, so we don't have any some kind of boundary or other things. So initially I was very hesitant to do some FMT because I have no confidence about the results of some kind of procedure and the price or something. But after the performing the national grant, it was I found it's very easy to approach and just to order, and I can receive some the stool. And usually we have some kind of IBS scoring to measure whether it is effective or not. So if we can perform the FMT with the science approach, with the patient's needs, then we can perform. But if it is not effective, then we should stop. So that's why we are wondering some kind of manuscript, and also right now we are preparing manuscript because to analyze the effect. My answer, yeah.
Okay. I am wondering, Professor Savarino, do you have your own stool bank also?
Yeah, we have. I mean, there are not so many FMT centers in Italy. There are 5 active, so, and they use their own stool banks. There is not a national stool banks to use for doing this kind of procedure. This is unfortunately a drawback in order to disseminate the procedure. But there are some movements in that direction in order to have it available in the next future for all the hospital who will need the use of this type of procedure. Can I do a question to Professor Shin or anyone who can answer? How long you can are you allowed to storage the feces in the stool banks? And the other question is regarding the selection of the donor and how many times you find some problems relating to asymptomatic condition, limiting the possibility of using the feces from that subject for doing the FMT? The first,
the storage time, and the first question is storage time.
the second question was related to the donor selection.
Donor
Yes, we-
selection.
Usually,
We have-
my
we have-
senior faculty professor Lee Dong-ho, usually he told me that 1 year, the stool bank, the storage time is 1 year, and even it's very, it is difficult to get, but just trash. And another question, another answer is that usually we donor is one, the physical, some kind of trainer, the family,
A physical trainer.
sports trainer, just one. So we have analyzed several times, analyzed the NGS for that stool, and we got some patent for several strains, and I heard 38 strains we found, and we are applying these two more effective or something effective the strain by the IBS model, the mouse model, water avoidance stress model, we got through. So right now we are trying to some kind of some clinical trial using that strains.
And is there the third question? I didn't hear.
Yeah.
That's all?
I got the answer. Yeah. It's a little bit different in Europe because the storage, the maximum time for the storage of fecal samples here is not really established, but it is suggested maximum 6 months, and then you have to eliminate the sample. And regarding the donor selection is quite complex because 90% of the time there is a condition which is apparently asymptomatic or invisible or not apparent for the potential donors, which obliged us to refuse the donation from that donor. Very frequently is blastocystis hominis infection in the bowel or other apparently not clinically relevant infection of the GI tract, which oblige us to remove the donor from the donor list, which is quite complex, I can assure you.
Professor Shin, do you want to comment about the material storage time and donor selection?
Okay. We screened the medical student, 50 medical students, and just one is passed the test. And we fortunately at the first time we have just one donor, but one donor, and fortunately that is like a super donor because its effectiveness of FMT and CDI and autism disorder is good, relatively good. So we stand the duration of the super donor as that just one donor, and compare with NGS result the candidate of donor, and as much as similar than that donor we select, and that student is Christian. In Korea, Christian has no drink, no regular diet, so we can control his diet and his lifestyle. So just one of the 50 students test passed. And second, our stool bank also just limited 12 months and then minus 70 Celsius degree in minus 20 Celsius degree within 2 months. And our refrigerator is minus 70 Celsius degree, so we use the stool within the 12 months. But we do the FMT rigorously. So just within the 6 months, the stool is already used. So 3 to 4 months, the stool is used
storage time.
regularly.
Okay. Okay.
It's very good to see that Korea super donor. I think we should facilitate an international consortium of super donors at some point. I know Norway has one. The data that Professor Savarino presented from Norway on the IBS trial, which was so hugely successful. They also have a very physically active, non-drinking, very healthy living person, and maybe we should, this should be something to think about in the future international league of super donors for FMT.
Yes, thank you. And I think there is no more questions. Can we end this webinar? Yes.
Yeah, thank you so much, Professor Choi, for moderating this session, Professor Shin, for such a wonderful presentation and giving us insight on the Korean perspective, and also the Korean data that you presented were very interesting. Also, Professor Savarino, thank you for taking the European side and giving us an excellent presentation and also discussion. This was wonderful. So also on behalf of the European Society of Neurogastroenterology and Motility and the Get Microbiota Health, we'd like to thank our Korean colleagues for allowing us to have this great interactive combined session. And I know we'll have another one in the future, right, Professor Choi? We haven't decided on a date, time, all of that yet, but we will publish that via social media and the website. And so from my side, thank you very much.
Thank you. Thank you very much. It's very helpful for us. See you next time. I think we may meet next year in London. Neurogastro.
Yes, of course. It would be lovely to welcome you all to our next Neurogastro meeting in London next year, because the Koreans have always been very, very active also on the European side, and we really love to welcome you all next year to our ESNM conference in London.
Okay, thank you very much.